been fit tested at CHOP, and then lo and behold, it was you. Yeah.
Look, it seems to happen in the PECC committee emails too, where I'm like, which one were you meaning to talk about?
Right. Are you sure? Oh, there's Kate. Hey, Kate.
Hey, folks. How are you?
Good. How are you?
Good. Nice to see you all. Your gorgeous faces.
Right. No masks.
That's right. That's right.
Thanks everyone for joining. It's great to see lots of familiar faces. If you are on an object that you can make yourself visible, we'd love to see you. If not, we can see your phone icon or your picture. Thanks. Thank you everyone for joining. We have a very punctual group here. So it's really great to see we already have 22 people on. So I think what I'll do is try to take roll call and make some ground rules as we all been getting used to with Zoom. So if you're not talking, if you could try to mute yourself. If you don't mute yourself, I might mute you as the host. This is being recorded. If you are not comfortable with that, I guess hang up. But there's a bunch of people that couldn't join today that asked if I could take some notes and record, so I'm going to do that, but just being sensitive to about what we say. It's not going to be shared publicly. I hope that people are safe and well and hanging in there, and our goal for today's meeting is really to have this quarterly opportunity of sharing and discussion of the community of practice, followed by a quarterly meeting of a webinar. So today is the more open forum, unmeeting discussion type meeting. So what I'm going to do is take some roll call introductions if I don't see your name. So I guess I can just confirm who is 816-918-9254. Nobody. 586-871-5336.
Hi, it's Dr. Pollack from Henry Ford in Detroit.
Okay, excellent. And I'm trying to see if there's any other one else with other names. 320-309-1287.
Hi, it's Kathleen Coulis from St. Cloud, Minnesota. Centrica.
Excellent, thank you. All right, and I think everyone else has their names up other than that. Oh no, there's a 586-871. Is that the same person I already asked? I'm sorry if it is.
Yeah, you already asked me.
Okay, for some reason you come up on two of my screens. Sorry about that. Okay, excellent. Well, thank you guys so much for joining. My name is Mark Auerbach, and I have the pleasure of co-leading this committee together with Teresa Walls, and we are a community of practice as well as a committee now of the American Academy of Pediatrics. So this group started as a special interest group, which means that it was a time-limited effort related to national pediatric readiness by the esteemed Kate Remick. And after some discussions amongst the community of practice, the American Academy of Pediatrics section of emergency medicine has decided to make this a standing subcommittee. There are some discussions about whether or not that subcommittee could exist in other places within the academy or within other areas, and this is still an open group, meaning that you don't have to be a member of SOEM or a member of AAP to participate, though we would encourage that if you would consider such. Since the prior meeting, we've had a lot going on nationally, to say the least. We want to thank again the webinar hosts and presenters from the last meeting, and those are posted on the EIAC website. But I really wanted to also thank Emery and some other individuals who nudged Teresa and I to engage hospitalists. So I appreciate that there probably are a fair number of hospitalists on the line, and the recognition that this is a shared mission of pediatric readiness, and that in many institutions there might not be emergency physicians or pediatric emergency physicians. We did have a number of dialogues with hospitalist leadership. There's a lot of enthusiasm within this section and committee on hospital medicine. And I will share after this meeting a really wonderful statement that came out actually in Pediatrics this month on the resources and recommendations for the care of pediatric patients in hospitals. So I think a foundation towards a element of pediatric readiness assessment at the level of the entire hospital or system. And lots more to come on that, but thanks for all of you hospitalists out there for joining us in the shared mission. So I think I'll pass it to Teresa for some of this ongoing business from the November meeting. And if you want to speak to the survey, and I know there's some other individuals that have been involved. Following that, we'll talk about webinars and then hopefully get to some new business and next steps. Were there any burning agenda items that I did not mention that anyone on this call wants to make sure that we address that I didn't mention here, really beyond the surveys, the updates on the webinars, collaboration with other groups, and then potentially discussion of the future during the pandemic, as well as national conference meetings.
I guess that's a no. Yeah. All right. So yeah, as Mark mentioned, we had been sort of talking, I feel like for maybe the past couple meetings, about some surveys. One being sort of a repeat survey of one that we had done over a year ago now, looking at what pediatric readiness projects are going on around the country and how we can assist each other and collaborate and figure out what's going on and what works and what hasn't worked. And so that we were thinking we're revising / expanding. When we got results of the first survey, we thought, oh, we should have asked this too. It'd be nice to know sort of exactly what kind of support is being offered for projects and what sort of time, if any, people are getting for projects. And so other than sort of deciding that it would be good to do that again, and I think we have a couple of COP members who had expressed interest in that, we're still sort of trying to get that off the ground to resurvey. So I don't know if we can sort of talk about that first before we get to the other newer survey. If there's anybody, I know that there are a lot of hospitalists on the group that probably weren't members of the COP when that survey came out, because it was a while back. And so I think even just re-surveying with similar questions might be helpful, but if others have thoughts or ideas or.
Yeah, my only question on that, Teresa, and I think Magna Diaz is on the line, this popcorn group that has started to talk about adult care in pediatric hospitals.
Yeah.
I'm just curious if that group is planning a survey or if that would synergize well with this. I've just heard about it as non-freestanding children's hospital. I'm not that familiar with that problem, but it's an interesting thing to think about, sort of adult readiness of children's hospitals.
Right, the flip side, I started a new community practice, yeah. Yeah, no, I've looked at the popcorn site because that's actually something that CHOP has been, dealing with over the past couple of weeks, and it's been an awesome resource. But yeah, I don't know if, if you want to speak, Magna, to that, any survey plans or.
Yeah, I am part of the Popcorn Network, but the part that's looking specifically at community hospitals. We had not planned on doing, we had planned on doing a survey around some of the newborn issues, because there's so much variation in terms of how people are dealing with newborn care right now with COVID positive moms. But we had not looked at that for pediatric readiness in terms of being ready for adults. So that's a great idea, though, and I think a good resource of the group if you wanted to spread the survey out more widely.
Great, and I don't know if everybody on the call probably knows what popcorn is. I forget what all the letters stand for, but it's a med-peds group, correct? That is working on collaboration between.
Yeah,
children's
it's a
hospital?
MedPeds group that really is working in a bunch of different spheres. So helping people who are doing inpatient care that now need to expand to taking care of adults, and how do you do that when you know, for
Right.
myself, I've done 25 years of only pediatrics. And then we're also looking at other issues. For example, you know, how do you, in a community hospital setting, besides taking care of adults, what are the other areas that you can kind of flex to keep that? And then we're also looking at recovery and plans for reopening and kind of the future of what needs to be done.
That's great. Thank you. No, I think that's a, you know, an interesting angle, like going forward, you know, just to further collaborate. Yeah, I think it'd be very interesting to see many of the things that you mentioned, how our group, you know, can get involved in. Any other thoughts, questions, suggestions about the original? So this survey, I guess, just to clarify, the target audience for this survey would be members of this group, of this community of practice. So just to get a feel for what kind of projects are happening in the community, in academic and community hospitals that see children. And so I think there's a lot of potential, a lot of different avenues we could explore there. So if I don't know, I think I have from the last call, but if anybody would be interested in sort of getting out the second wave of this survey, either just give a shout out now or send me a quick email, and then we can work on that going forward.
Hi, Teresa and Mark. I have one question.
Yes.
Can you guys hear me? Oh, hey, this is Kamal. So the question about the survey. Sorry, I lost a lot of trackings in the last AAP meeting in New Orleans last year. Are you guys planning to look or survey only the community hospitals that are doing some pediatric readiness effort, or you're looking at the academic center and their collaborative effort as well to engage your community partner in their own region or cities to initiate readiness effort, whether in the ED, or in the hospitalist, or in the other community setting? I'm just curious about the scope of the survey. Is it going to include both community and academic, or what's the plan?
So that's a great question, Kamal. I would say that the initial survey and the initial intent of this was to build the community of practice, which would allow us to have a shared set of resources and learn from and with each other. So I put that, tried to put it in the chat box, really understanding what people are doing related to pediatric readiness across the country, whether it's research, education, advocacy, understanding if they have supported time, resources, where that's coming from. And it had initially really been focused on the children's hospital. My hope is that with having Magna and other hospitalists now engaged, that we can also survey that with work that's going on in the community hospital as well as collaboration. And I think the long-term effort would be, you know, a more rigorous survey. I think this first effort, I think a survey, just to be careful with their nomenclature, might not be the right word. It's really just helping to survey the people, not conduct a research survey to understand what's going on, populate a website, and share with the community. Would you say that's on point, others, with our prior conversation? I just want to make sure I'm speaking with your
Yeah.
Primary goal is for you to
I apologize if you can hear my kids fighting in the background. I'm getting, I'll mute myself shortly.
Does that make sense, Kamal?
Yeah, absolutely, absolutely. It makes full sense. I just want to make sure that
I'm going to post what was the survey 2 discussion, which is what came up at AAP, which was really more from a models of care standpoint, understanding what models of care exist. And again, this is something that I think is a much more challenging process and probably needs to be done in a more rigorous way so that we could perhaps generate some scholarship about it. But looking at you know, the existing models to support pediatric care in communities, so whether it's the model that Kate and their team has described in the recent webinar, or that Sarah described, or a variety of other models at the level of either the health system, a state, or an organization. That's, I think, a separate survey and looking at trying to understand what models are out there and what the best models are. And that's more on the systems of care aspect. And this survey would be more on the individual aspect to help create this network. But we could adapt that or abort both of those or move away from both of those if people don't feel that they're useful. The first go around, we definitely did collect some information and we're able to structure some of the webinars and make some virtual connections with that. Comments, questions, interest in owning / leading one of those survey processes from anyone? Okay. So thank you to those that have presented on the webinar. I see that Kamal was interested. If anyone else is interested, text or email Teresa or I. In terms of the webinars, we really, I think, have been very fortunate to have a great showing, as well as a very supportive EIIC who's posted the webinars on our page on their website and been able to get content out to the community. Ideas that were still on our potential to-do list from prior discussions were scholarship in pediatric readiness and a particular focus on critical or access or rural hospitals or even Indian health services. And work in pediatric readiness in those areas. And then Teresa and I, started to say that COVID might be a potential topic, but people can either put in the chat box or comment if either any of those topics or they had additional ideas for topics of focus for webinars. Or community of practice meetings that involve a presentation and a discussion, because it's a little bit different than a webinar, hopefully. Everyone's very quiet today. I think people are zoomed out. Okay.
This is Jessie. I don't know if this is a great suggestion for a webinar or not, but I've been getting a lot of questions from my team colleagues around the country about how to, kind of in line with popcorn, how to prepare for COVID, because I'm in Seattle, like what we did. And it might be worth having a webinar on both hospital preparations for a potential surge in a pandemic and also pediatric hospital preparations in line with popcorn for taking the overflow of adult patients, and how to work with, as a freestanding peds hospital, how to work with your sort of adult hospital colleagues. I don't know if it would fit the focus of this group, but I know there's been a lot of ask for it in the last month.
Thank you, Jesse. What are other people's thoughts about that? And Jesse, would you be saying, would you frame this as more children's hospital preparedness for adult patients? That's what I'm hearing. And I'm just wondering if there's a way of framing it. And I don't know, Magna, if you've thought about this being in a community hospital, of perhaps even, community hospital or children's hospital, sort of pediatric acute care, inpatient people that are thinking about pediatric readiness, how they might need to expand that scope. I don't know, I'm trying to flesh it out. I don't know if other people have ideas or thoughts.
Yeah, this is Mo. So I think that it really depends on where you are. So if you are a PAM provider and your day job is to take care of kids, but now your pediatric volumes are lower, and either you're in a children's hospital where you have all these resources that you could help, adult patients, or if you are in a general type hospital where you're a peds ED attached to a adult ED, or whether you're a community hospital, I guess the question will become, how can people who specialize in peds, in light of lower peds volume, help their adult colleagues? Along the lines of, do we start seeing some of the older patients beyond 21 who have simple stuff that we can take care of? Or can we have nursing resources that can be shared? Can we set up our rooms in a way that they can take care of adults? So there's many different strategies, all depends on where you are. So it'll be interesting, actually, as Jesse was suggesting, it'll be interesting to see what different kind of environments can adapt to caring for a larger group of patients than what they're normally doing, so that we can efficiently use all of our resources. because a lot of places are talking about, cutting down the hours of their peds people because they don't really need them as much. So in our hospital, for example, what we're setting a backup system that we can help the adult a lot more than we were doing before. It'd be interesting to see how different people are doing that, and perhaps look and see whether we can make a list of things that we can make as a recommendation moving forward. Again, I don't know if it's a scope of this group or not, but if we're talking about pediatric preparedness, I guess we can say it is related.
Okay. So I just put oh, sorry, someone else was commenting. Go ahead.
Mark, it's Kathy Brown. I think that might be useful, but also just general pandemic or epidemic preparedness. I think even in a lot of the children's hospitals, we were caught off guard in regards to things like PPE, even hand sanitizer. Part of Peds Ready is disaster preparedness too, right? So I think even those of us who thought we had a good hospital disaster plan were caught off guards in some ways by this particular pandemic.
Okay.
And then one other thing, totally separate idea for a webinar, is the pre-hospital Peds Readiness Project. If this group would be interested in hearing more about what's going on with that project.
Definitely. Yes. So I think that I put up a poll, but I didn't have that idea at that point, Kathleen. So I think that this concept, something related to popcorn, pandemic preparedness, and something related to pre-hospital PEDS readiness or PEDS readiness across the continuum, we could even think about, where we're thinking about the hospitalists as well, all sound like great topics. If people have any other ideas, please put them in the chat box, and not a formal poll, but I just figured I'd throw something up on there. In terms of any other discussion people want to have about the webinar or next topic areas?
Well, just along the topic of, readiness in a community setting where we're a small pediatric department in a large community hospital, one of the issues that we came up with is that we weren't necessarily sitting on all of the right committees. And so they put together visitor restriction policies, and we had to really work then to say, hey, wait a minute, these visitor restriction policies that you've come up with for the hospital don't make sense for pediatrics. You're not going to leave a 2-year-old in the hospital and not allow any parents to be there with them. And so I think that, ideas as to how to make sure that pediatrics is being looked at when we're only a very small percentage of the total hospital are important.
That's fantastic. And who was that commenting? Sorry, I couldn't see who was.
Sorry, Mark, it's Kate.
No,
Sorry,
who was
go ahead.
speaking? Sorry.
Leonard from Henry Ford.
Oh, thank you, Leonard. Appreciate it. So Leonard, I think that's a great point and fits in really nicely with this idea. And I think we could, target some community hospitals and children's hospitals in that way, which I was worried hearing from Jesse initially, that I didn't want to be overly children's hospital centric. The other idea that did come up in the chat box, which I love, is the concept about telemedicine. And another person brought up the concept of mental health readiness. So I think that we have a nice set of items here, and we will work depending upon who can make it at different times to prepare for those topics. Are there any other items that people can think of? I think the mental health, the telemedicine, certainly, and pre-hospital all dovetail pretty well with some of the things that we've learned during the epidemic.
This is Kathy Kulis from St. Cloud, Minnesota. I'm also at a community hospital, and I would just like to echo what Leonard said. That totally applied to us as well. In fact, I was just reviewing our incident command action sheets and was going through the Code Blue one, and it talks all about the adult Code Blue readiness and Code Blue carts and PPE, but it didn't say anything about what would happen if there was a PEDS Code Blue, so I had to, advocate and push to get that changed as well. One other thing is just going back to, I know Magna had mentioned the nursery care and newborn care. So at least in our hospital, the newborns aren't counted in the overall census. And so sometimes I feel like we really have to advocate for them as well.
Excellent, thank you. Any other ideas people wanted to share?
Mark, this is Kate Remick. I was just going to add that if you have any questions about who might present, because I saw that one of your items for the survey was scholarship in pediatric readiness. And I suspect there are folks on this call and in this group that know of people that are engaged in various projects. So if you're looking for maybe a list of ideas of presenters, that maybe this group could submit some so that we have some ideas of people who might be willing to share their work.
Yeah, and I don't know if this is where you're going, Kate, but maybe even adding in survey questions when Teresa sends that back out with the topics related to the topics and speakers. I think that's a great idea. Thank you. I think we've hit everything that I was hoping to hit, which is getting some awesome ideas from the group about topic areas and areas of interest or focus. My suggestion slash question for the group is, how do we continue the community of practice mentality and shift from the webinar mentality? And perhaps it's happening already, but I'm going to lean on you know, those individuals that have participated as presenters in the webinar, community of practice webinar, you know, to hear from them. Did it result in people reaching out to you in facilitating collaboration or shared learning, whether you were a member attending or a presenter? Because if it did not, then we should just try to think about how we can structure the subsequent sessions such that they do, because I think, again, it's easy to fall back on the traditional, this is a webinar, we're going to spit out information, and really the community of practice construct is that we're sharing and that there's a lot of ongoing activity amongst different pockets of it. So I don't know, Sarah, I wonder if you're still on, if you want to comment, or if any other presenters on the prior webinar want to share. Chris, Emery.
Hey, this is Mo again. I can just share that we did a webinar a couple of weeks ago for ACEP's section on pediatric emergency medicine. We put something together really quickly, and all it was is basically an information session about COVID, and I was one of the presenters. Ross Megiddo from Seattle was one of the presenters, and Ethan Wiener from NYU. So we looked at the three areas hardest hit: California, Washington State, and New York. And we basically gave our impressions of how we are experiencing everything. And it was great in a sense that we had over 500 people register and over 350 people attending the webinar. And that was really only with a 2-day advance notice. So the good news is that at the current times, you know, there's a lot of people who are available and paying attention to things that we wanted to share. Also, Zoom seems to be an easy modality to get people involved. We did get a lot of engagement, a lot of feedback. A lot of people said they wanted to do more of them. But we found that after that first one, again, the whole idea of we're tired of Zoom a little bit now, it was harder to arrange subsequent follow-up webinars. We also didn't know what else are we going to do. Are we going to keep updating the same information, or what is really best for people? So I would say if we have different types of webinars that are going to have completely different topics, per webinar, you're going to get good engagement and people are going to be interested. My experience was that it is very, very difficult to do follow-up kind of engagement, what the intent of the community of practice is. Just based on my experience, we probably have to do something a little bit differently than what we did. But you definitely get very good initial response on doing these kind of webinars.
Thanks, Mo. How about from the presenters on prior webinars? Again, this is kind of more of a format question and maybe even a nomenclature, but you know, Emery, Sarah, Chris, perhaps you guys have had like 1 million people reach out to you and you're doing all sorts of work that this is propagated, but I think, you know, we want to have the presenters as well as the attendees be accessible and interacting with each other. They're intended to be sort of kindling to start the fire, not as the only aspect. So I'd be interested if people have ideas on how to do that.
You know, stepping back, one of the really interesting things going on right now, I think, is the whole area of how pediatric emergency providers are helping in this environment around adult care. And I know at our place, we've had anxiety. It's a little scary. We're seeing adult patients, and in fact, our PICU has become a regular ICU being run by the PICU attendings, seeing 50, 60-year-old COVID patients. So I think there's a lot of variability out there as to what's happening with this. And I think it may be interesting and of benefit to people to have an opportunity to start seeing how different people around the country are dealing with this.
Thank you. So perhaps that brings us to the next, I think the final bit of business that came up during the discussion with the hospitalist group. And I'm hoping Kate is still on and can give her thoughts on this. What started to come up in that discussion was the recognition that in each institution, there's sort of the pediatric readiness champion, and that may be a nurse, it may be a physician, maybe a peds emergency provider. But how do you begin to engage other sections or entities within the AAP or other organizations? And some that came up in the discussion with the hospital section were transport, critical care medicine, pediatric surgery, urgent care. I think that it's just something philosophically I want to explore with this group, because I think we have a fairly large group that's getting to the point where it's almost too large. It might be difficult to manage. And I'm just going to start out with my thoughts, which is PDM, hospitalists, if there are other members now, that's great, but not necessarily being proactive about those other groups. But I'd be interested to hear if people think differently. We do want to work across the continuum and not exclude people, but there's a difference between actively trying to engage, for instance, the section on surgery or the section on transport or the section on critical care within a society.
I guess I have a question. You talked about a pediatric readiness champion. Do we have any documents that actually define what that role is? Whoever is taking that role?
So we do from the emergency department perspective. I am not aware of that from a systems or a inpatient peds perspective. There is the construct of a pediatric emergency care coordinator that I think most of those elements that we think of fall into, and that role has been described in both pre-hospital as well as hospital-based care. I don't know if other people are aware of other terminology or roles. We have heard from individuals that there are organizations that have overall pediatric champions, like we heard from Sarah Ellender, that she's sort of functioning in that role for their health system. And I know that's starting to emerge, but I don't believe that there's a standard description for that outside of the pre-hospital and ED environment, unless people know otherwise.
Part of the challenge of creating a standardized pediatric emergency care coordinator role has been the ability to link that role directly to improvement in outcomes. And there's been a lot of efforts underway to try to identify those most critical elements to improve pediatric readiness and thus pediatric emergency care delivery and ultimately outcomes for children. But because of the challenges with that linkage, there's a lot of variability in who those champions are. Massachusetts ACEP has defined what the role of a PEC could be, at least to start with. The PEDS Ready guidelines that Teresa mentioned in the chat box also define the role of the pediatric emergency care coordinator. It's highlighted in the national assessment that was published in 2015. And it's also been identified or spelled out through some pediatric readiness quality work that's been led through the EMSC Innovation and Improvement Center. So there's a lot of different models, but there's not one single standard until we can better link those activities with improved outcomes.
Anyone else familiar with things on the inpatient side of the world or in the hospital administration side?
Well, yes, from both. I'm a pediatric hospitalist and also the regional lead for our health system here in Southern California. And so that's why I was asking, because if there is no clear defined what this role would be, whether it's inpatient, pediatric readiness, ED, pre-hospital, that would actually be a good starting point so that everybody's speaking the same language. It sounds like it kind of means different things to different people. And even though there may be more defined roles pre-hospital, to me, I don't even know. We have a program, supposedly, there's our ER group is working on it, but I'm not even sure what standards they're using. And I don't know what the roles are of all these people. So, and what they're responsible for, because we're all children's hospitals within hospitals. We have 3 of them in our system. And then we have 2 community level hospitals that admit peds patients. And then we have 11 hospitals that do ED care for all ages and don't have any inpatient peds, but have NICU and deliveries there. So there's a great deal of variability. I'm assuming that throughout the country, there's this amount of variability. And to me, just hospital readiness, pre-hospital readiness, ED readiness, I mean, we should really be working on some sort of clear guidance on that, understanding that maybe there's not a lot of literature in terms of quality improvement on some of it, but it would be very worthwhile, I think, to do some of that work. To help people that maybe don't have the resources, especially in rural settings, community settings, Indian health settings, things like that. So that's the reason I brought it up.
No, thank you. And can I just clarify who that was speaking, just because it's hard to track within Zoom?
Oh, I'm sorry. This is Dimple Kona. I'm at Southern California Permanente Medical Group.
Okay, thank you so much, Dimple. So Dimple, I think that's—
Hey, Mark, can I just jump in really fast and speak to that? This is Kate. The roles of, or the role of a PEC has been very well described. It's just that most hospital systems and healthcare systems have not invested in the role, and that's really why there's so much variability. And so you'll see some individuals that are really focused on quality improvement efforts, others that are focused on education and knowledge reinforcement among their staff. But when it comes to the children's hospitals, I think the EDAP model that exists just up the road from you in LA County is a really nice model of what a pediatric emergency care is or does do. And so in LA County, every single emergency department approved for pediatrics has that pediatric champion where their roles were very clearly defined, and they actually are in the Illinois facility recognition system that was developed through the work of Evelyn Lyons as well. The PEC has also been well defined in the pre-hospital setting through the most recent joint policy statement, as well as a former position statement that came out of NAMSP. I agree that in the in-hospital setting, there hasn't been a well-described or well-defined pediatric emergency care coordinator or in-hospital care coordinator. And that would be, I think, really critical to help align the pediatric readiness efforts across the entire continuum. But I just wanted to create some awareness that the role is well defined. It's just that it hasn't been widely adopted in its full form.
Yes.
Because the cost,
Yeah, thank you, Kate. So I think that gets at least the conceptual framework for why Teresa and I and a number of others, Steve Janofsky, had begun to bring up this idea of the second survey of understanding the existing models. And I'm wondering if even narrowing down that survey to something related to a pediatric champion or leading pediatric efforts, because really I think what you're getting at, Dimple, is the struggle that if there's no funding, then you don't have someone that's actually doing all the things that are perhaps designated as PECC roles. And if you don't have someone doing those things, how do you produce the value? But I would say that within many organizations across the country, there are programs in place and people in place, and perhaps understanding those models might allow us to replicate them. Steve, do you want to just talk about your experience in the Pittsburgh area? Because Steve's a graduating fellow and really did try to say, okay, can I collate information about these positions from different people to hopefully create what I can bring back to my senior leadership to say, we need to have a PECC, and not say we need to have a PECC, but actually say we need to have a PECC, which means X, Y, Z, and Q.
Yeah, so this is Steve. That sort of was my experience. It was sort of we did it informally through Mark and Kate and Teresa and a few other folks. But yeah, I mean that sort of was what we tried to do, was take some of the policy statements that have been written, take some existing positions and pull some needs from our system and find out where the two meet, and then go to our senior leadership in Pittsburgh, who ultimately approved sort of a regional PECC position for me here coming up. So I mean, I do agree. I mean, I think that there's a lot of newer literature out there, as Kate mentioned, describing what these positions might entail. I do think I mean, this is what we had talked about in terms of the survey, like Mark mentioned, getting a better idea of what is happening, what models are successful, and how they might differ from place to place. I think one of the struggles that we've had, I mean, I think part of it is time. We've all been sidetracked, obviously, over the past couple of months and trying to get this off the ground. But I think as you were alluding to, Mark, I think a direction for the survey, I think makes some sense in order to figure out what question we're trying to answer, and I think that this one might make sense.
Yeah, and I think from what I'm hearing from it, Steve, it's perhaps shifting from, do you have a pediatric emergency care coordinator? And I don't know what the term would be, but something about, an individual, that might not be familiar with the EMSC literature, that might be a hospitalist that might be serving in this role. But I think we could try to flush that out and work towards it. Thank you, guys. And I know we're getting towards the hour limit. We still have 17 more minutes, but I know that's an hour is quite a long time on Zoom for many of us being on Zoom throughout the day. I wanted to sort of open up the floor to any fellows or trainees particularly, because one of the areas that we identified at the AP meeting in the fall was trying to create a career trajectory, so to speak, where people would see pediatric readiness work in this area of work being a potential career path. I think for many of us that have been working in it, we've sort of seen it as a hobby, or not a hobby, I don't know the right word. It's a passion, an area of passion, but perhaps it wasn't the focal point of our careers and has become that. But I'm just interested to hear from any of the fellows or trainees how we could potentially support you, and or if you have any comments. I just see at least 4 or 5 names of trainees, which is really exciting to me because one of our goals was to engage trainees.
Just one other quick comment on that topic, Mark. As
You
a
could talk. You're a trainee still, Steve, for another 3 months.
Yeah, as a trainee myself. One thing that we're going to be trying to work on in our fellowship program with 1 or 2 folks who are coming in and who currently exist in our program. We have a model in our fellowship program where we have these like career tracks, and many of them fit into traditionally sort of defined roles in pediatric emergency medicine, whether it be like research or clinician educator or medical education. So we have a few newer ones that have been developed. Ultrasound pre-hospital has just developed a track in the past year or 2. And we're talking about developing a similar one based on what I've hashed together through my fellowship. So that would be something that we could, once we develop sort of our curriculum and path and different resources, that's something we would be happy to share with the group in terms of both getting feedback and also providing a little bit of guidance about the opportunities for trainees who want to become more expert in this field.
Great. Steve, within that, one of the things that had come up was potentially even like a slide deck or a pitch deck on pediatric readiness that we could provide to fellowship programs. So it might be worth exploring that just to sort of get it and get implemented in part of their curriculum, whether it's a slide deck, but something to get fellowship directors sort of ensuring that their fellows and trainees are aware of pediatric readiness work and potentially even residents. Any other comments from trainees?
Hi, my name is Sabina. I'm a fellow at the University of Rochester. I'm really interested in pediatric readiness, and so I've been interested in this group, and I visited a couple of the meetings at AAP. So I just wanted to introduce myself, and I'm looking forward to kind of seeing where some of these projects go.
All right, I know some of the other fellows, and it might be hard to talk when there's 30 attendings or others on the phone and leaders and such. So thank you guys for joining us at least.
Hey, Mark, can I ask you to make one comment, if you don't mind?
Yeah, go ahead.
Can you make one comment about, Philip was asking a good question about, the utility of a champion that doesn't have funding or a formal position, but yet can do some and execute some of the PECC readiness work. Can you make an overarching comment about how the champion yet can do work even though they're not funded or formally positioned by the ED? The PECC champion can do some meaningful work at the community settings for pediatric readiness.
Yeah, I'll try to comment on that, and I'm hoping Kate's still on so she can comment, because I would say that philosophically my feeling is that doing any pediatric readiness work is better than no pediatric readiness work, and at least with the hospital and pre-hospital PECC roles, our strategy in Connecticut and even with some of the pre-hospital collaborative has been to use building blocks, and that oftentimes it may be unfunded, and I think in Massachusetts the same way, and created structures and tools so that it's easy for PECs to do parts of their job well. So for instance, an education toolkit. But I'd be interested to hear from Kate, because I think that one of the challenges is that people can get overwhelmed. And with the pre-hospital PECC role, they looked at this and are like, okay, we have 3 EMS providers, and this is basically a full-time job you're asking me to have someone do.
Yeah, I would say just like building any scholarly career, it takes kind of building that up before people realize that you have the capabilities in place. And so one of my recommendations would be looking into small amounts of funding, even seed grants and things like that, that can help support your efforts within a network or within your own individual hospital. And as you begin to demonstrate the benefits of your work, then people start to buy into it and are therefore more willing to support it. If you're interested in a model of that, I would actually go back to one of the webinars that Sujit Iyer and I gave together. And we kind of outlined some of that work that we did early on, which was initially just volunteer work, and then a small amount of grant funding, And now Sujit has a formal role where he is not only carries a title, but also authority and has protected time to improve pediatric readiness within his network. So I just think it takes a little bit of time and dedication to build it up. And there's some easy wins to start with, which is, starting with looking at gaps and starting to identify resources for purchasing needed equipment. And then it's engaging folks in either SIM-based education or other educational modules like Mark has led, or potentially in quality improvement efforts. And then slowly you're able to actually measure your progress and demonstrate that, and then you get buy-in. So it takes time. Hopefully, as more and more of us do this, it'll take less and less time, because my hope is that we'll begin to demonstrate through numerous scientific studies that pediatric readiness indeed makes a difference, but it takes those of us on this call to kind of start that up and get moving with it.
This is Mo. One other thing I was going to say, to just add to what Kate was saying, our LA County experience was actually pretty good. We realized that by having a pediatric champion per hospital, but also having a PECC that covers multiple hospitals, it would be really good, like when one hospital is doing a lot of great work, and then that PECC knows about the one hospital and kind of infiltrates that information to the other hospitals, kind of gets everybody to kind of pull up together. But one challenge that we had was just basically you need leadership buy-in on things like that. And we had a tremendous number of turnover in leadership on those community hospitals that were part of the group. So you finally finish convincing one hospital leadership group that this is good to do, and then that person is gone. Next thing you know, we don't have any more contact information. We don't know how to get a hold of them. So it's very important to have something concrete that is already built up, so that when the whatever transition of leadership happens, that this doesn't completely drop. And I felt that the idea of having a regionalization of the PECC, having one PECC, for example, oversee 5 or 6 different hospitals and work together closely with each of the pediatric champions, was a model that seemed to work very well in case of the transition of hospital leadership.
Yeah, thank you, Mo. So I did want to ask some of the hospitalists on the line their thoughts on this, because I think until AAP and this discussion about integrating hospitalists into this discussion, it hadn't come to my mind. And I think in many, whatever, 5,400 EDs, I don't know the exact number now, most of them do not have pediatric emergency care providers. I'm not sure how many of hospitalists, or if we even know that, but certainly bring some of this education to pediatric residents, who obviously are getting a very different experience during their residency at a children's hospital. But do any of the hospitalists have thoughts on that? Do they think that, a target to some of the community hospitalists to serve in this role as pediatric champions would be reasonable, or is that not a reasonable strategy for the community?
Hi, this is Kathy Kulis. I'm from St. Cloud, Minnesota. So we're about, 70 to 90 miles northwest of the Twin Cities metro area, like where the children's hospitals are. We have a family medicine residency program at my hospital, but my health system, it consists of a main big hospital, like a 450-bed hospital. And then we also have five critical access hospitals that are fully staffed by family medicine, so not even necessarily adult ER medicine physicians. And I just, as you guys were talking, a couple different thoughts came through my head. One was it would be really nice to have a toolkit. Number 2, I thought, man, I wonder if I could tap into the PEDS residency program down at the University of Minnesota to see if there's a PEDS resident who's maybe going to go into PEM, could be interested in doing a project at our health system to, do a gap analysis and just look at maybe what our needs would be, and then that could be kind of an ongoing project. Or if there's a EM fellowship program, if one of the fellows would be interested in doing something like that as well. So you're definitely sparking some good ideas in my head.
can I build on that a little bit? This is Lindsay Query. And I'm in Kansas City. I'm a pediatric emergency medicine provider. And I work in Kansas and Missouri with EMSC on readiness stuff. And I love the idea that you just put forth. What I would say is that I feel like I would love to do something like that. I mean, I'm a PIM faculty, but I would love to do something like that. But in my own state of Missouri and Kansas, I don't know which hospitals have what resources in terms of hospitalists or health systems. It seems that nobody does. And even more acutely in the setting of pandemic, things that we've talked about is that we don't even know where pediatricians' offices are. And it's something that has crossed my mind because I've seen a lot of patients driving from really long distances to get care, and it's coming up anecdotally that their pediatricians' offices are closed or their health systems are not seeing patients. And these aren't necessarily novel, but I wonder if there's a way, or if anyone has insight or has done this before, about creating a network of a map almost of where pediatricians are, whether it's hospitalists, PEMs, ICUs, NICU, where are they, and is it easily accessible? Does anybody know if that exists?
I do not believe it exists. It may be out there in data form from the AAP or ABP. I think it's a really interesting question, Lindsay. Does anyone else know if that exists?
I was just going to say, I don't know that it exists on a national level, but each state's hospital association often has just some high level data in terms of hospital capabilities. But I don't know if it would get to the level of detail that you'd be interested in. It would just be a matter of reaching out to them and seeing what they would be allowed to share. But that's the only other thought that I had as you were talking.
Because I love the idea of connecting.
Oh, go ahead.
I was just saying, I love the idea of connecting, and I've gone to the Missouri Hospital Association and even the Missouri AAP and different state organizations that I would think have that data, and it's not very granular at all if it does exist. So it seems like very much a boots on the ground kind of effort.
Well, the other problem that we're seeing in our area right now is that even if you had that baseline data as to where these places were before COVID, right now when we're in the middle of the pandemic, there are lots of offices that have closed or have said, well, we're only going to see the well child visits and we don't want to take the sick kids. And there are pediatric units that have closed and totally become adult units and said, oh, we're just going to have any of the sick kids go to the children's hospital. And so it's not only a matter of needing to know where they are when times are good, but it needs to be a way that can be updated in real time when things change.
That's dynamic. I agree.
Thank you, Lindsay. I think that was a great comment, and I think an important area to explore related to what I'm hearing is sort of connecting, the children's hospital and/or people that are passionate about this work with the people that might need those knowledge, skills, and resources. I did put in the chat box, and I want to make sure everyone that is new to the group is familiar with the Joint Policy Guideline. So I put a link for that, as well as the EMSC EIIC Improvement Center. So many of the resources, the toolkits, the descriptions we've been talking about are available in those places. And I think that the discussion today helps at least myself and potentially Kate and others to think through how to best get those resources out to people in a way that they can digest them and use them, because some of the things that were requested certainly with toolkits and guidelines are available, and I think how to make people aware of them and make sure that they're fitting people's needs and are useful is really important. So we have about 1 minute left. Does anyone from the hospitals group want to make a quick comment to integration with hospitalists? And Chris mentioned family practice providers. Thank you. That's an important group too.
This is Kathy Koulis. I would just to mention I am a hospitalist and we
Great.
don't have any PGR in our
Okay.
system. So I just wanted to throw that out.
Okay, excellent. Thank you, Kathy. So I think we'll end just to answer Philip's question here. There is a dynamic listing of active projects I mean, a listing of active projects is not necessarily dynamic that we collected on the first survey. The second survey, we're going to work to be a bit more thoughtful about asking if people are looking for others to get involved, which we tried the first time around. But if people are interested in a specific area, I received some private chats, reach out to Teresa or I, and there's many individuals on the line who have expressed a passion to engage others in their work. We really appreciate people taking the time to come to the session today. Again, we know everyone's super busy. I think we will plan for, just for action items, we'll plan for a webinar on pandemic and epidemic preparedness involving, from the lens of the pediatrician or pediatric provider. I think that's a really fascinating thing to think about from the Children's Hospital and the community hospital. And I think we could get both those perspectives, having Leonard and Kathy and some others on the line. In terms of the next meeting, we will plan for a webinar, and then in the fall, hopefully we'll be in person, but if not, then we'll plan for another meeting online. We do have the results of the survey on the EIIC website. If you search Pediatric Readiness Community of Practice, I'm going to try to do that in the last minute here, but if you search Pediatric Readiness Community of Practice on the EIIC website, you can link to that. Thank you so much. I'll stay on the line a few minutes if anyone else had any other questions or comments. Happy to continue a dialogue for the next few minutes, but really appreciate your time.
Thank you, everyone.
Back it out.
Hey, Mark.
Hey.
Hey, I was just wanted to ask real quick, because I've been trying to work both for my own projects and as well as with Liz, trying to get ways of starting like grassroots projects and particularly engagement. You kind of mentioned earlier where you have a webinar, everyone gets really excited, but then people kind of like drop off. And, so I was trying to figure out, in an unfunded project, are there ways that you guys have learned to create and maintain engagement?
What I figured he did is, and then
like, to create a champion and say, all right, now this champion's gonna like actually like run the distance with us.
Yeah, so I think it's all about relationship building. So I think if you can find that community provider that's willing to collaborate with you and begin to demonstrate a proof of concept and success, that can spread. And I would say as a fellow, that's a really nice approach, as opposed to trying to implement a massive project, perhaps finding that partner or a small number of partners and implementing something. And I think you could take either approach. You could go to implement the full PECC role, as Kate has done, or you could take more of that building blocks approach. I would suggest reaching out to Joyce Lee, who's done a lot more of this grassroots concept of PECC creation in Massachusetts and then brought that to all of New England. So I think that her strategy, and she's just writing it up now, of really taking more of a, okay, I'm going to be a facilitator as the PEM person and sort of reach out and get in touch with as many people as I can to have them assign a pediatric emergency champion in their department, and then figure out what to do with those champions, as opposed to as a champion, you're going to need to do X, Y, and Z. But Emery and Joyce, talked a little bit about it. If you want to look at the webinar that they gave, and then potentially reaching out to them, But that's on the MSC website,
Thanks, that'll be really helpful. But all right, cool. Thanks for the invite. And
all right, excellent. Chris, are you still there? You just didn't hang up yet. You want to chat? Hey, Chris.